So the organizers really didn't want me to, bomb you all with study data and clinical trial data. But my basic aim would be to, make it simple and try to generate some interest in cardio-oncology and introduce this concept of cardio-oncology to all of you. So I would start with introducing cardio-oncology and Asian Cardio-Oncology Society, our endeavor. Talk about the relation between breast cancer and cardiovascular diseases, some basics of cardio-oncology before treatment, during treatment, and after treatment, the concept of cardiovascular evaluation and risk stratification, preventive measures, and CTCRD identification and management. We'll go to individual toxic therapies like anthracyclines, anti-HER2 agents, RT in the perspective of cardio-oncology, and talk about long-term follow-up. So, why are we talking about cardio-oncology? Why are we not talking about pulmonary oncology or nephro-oncology or dermato-oncology? Because the cardiac diseases and cancer are really closely related. Now, cancer and cardiovascular diseases are the two most common causes of death and morbidity worldwide as well as in Asia. And the trend is only increasing day by day. We have increasing life expectancy and age, and because of it, more and more cardiovascular diseases and more cancer diagnosis. And because of better cancer treatment, we have better cures nowadays, and hence we have more cancer survivors and more cardiovascular diseases because of the anti-cancer treatments. Now, when we look at any cancer clinic, we see that many of the patients are already having cardiovascular diseases, or they are going to have cardiovascular diseases as a result of treatment. And we're already talking about the concept of reverse cardio-oncology. That is the increased incidence of cancer being found in cardiovascular diseases. And this is already emerging concept. When you look at the different anti-cancer treatments, now every anti-cancer treatment you talk about, there is one or the other cardiac side effect that are going to there. And with the explosion of newer and newer anti-cancer treatments, we are going to see this more often. So, what is cardio-oncology? So that is what the need of the moment is, that we need a coordinated care and a team effort from the treating oncologist as well as cardiologist in order to have a better outcome for all of our cancer patients, in order to prevent and to treat cardiotoxicities which are there during and after treatment, and to ensure that we have a healthy heart and continued cardiac care while we are continuing a potentially cardiotoxic treatment which is life-prolonging and uncompromised treatment of that life-prolonging treatment, taking care of the heart. So the problem is that in the Western countries, cardio-oncology is already an established branch, and you have cardio-oncology clinics in every cancer institute. But when you talk about the Southeastern Asian region, India, Bangladesh, and most of the Asian countries, we lack this cardio-oncology team in most institutes. And when you look at this problem from an oncologist perspective, now we are not confident of our cardiologists actually understanding the scope of cardiotoxicities of the modern anti-cancer treatment. Now the other day, one of my patients whom I gave pembrolizumab presented with myocardial infarction. And I was debating with my cardiologist that, look, this is an immune-related event. But my cardiologist was saying, no, this is a classical myocardial infarction. And when he did an angiography, he did not find any clot, any blockage. So, you don't find your cardiologist, even the experienced one, understanding the scope of anti-cancer treatments in this part of the world. Also, when you talk about echocardiography, according to a survey that we did, what we found is 30% of the echocardiograms are actually not done by cardiologists themselves. It is either an MBBS person who is trained in some have received some training in cardiology, or some technician even doing echocardiography at several centers. And when you talk about cardio-oncology, you probably have only 2 or 3 centers in India and in this Southeastern Asian region actually having a proper cardio-oncology clinic. So our cardiologists are hardly interested in oncology. They are more interested in putting stents and intervention. And when we talk to a cardiologist and try to understand this problem from a cardiologist's perspective, what we understand is most of the oncologists, we are not really concerned about the long-term cardiovascular effects. Now, when a patient comes to our clinic, we hardly look at the blood pressure, we hardly look at the cardiac symptoms. We are only concerned whether they are having neutropenia or not, whether they are having nausea, vomiting or not. And we focus only on the cancer and the oncological outcomes. The long-term cardiovascular toxicities don't really matter to us. The cardiologists, we do consult them, but only for acute events. But rarely do we consult them during the treatment or for a follow-up treatment. And during the cancer treatment, what we see is that the cardiovascular care decreases, and most grade 1 or grade 2 cardiotoxicities are rather ignored. So the solution is that, from an oncologist, as I am an oncologist, I feel that we all must make ourselves aware of basic cardio-oncology ourselves, and we must have some effort to engage the cardiologists into this discussion so that we have achieved best outcomes for our patients. So with this aim, we started this Asian Cardio-Oncology Society 2 years back. It is already a running society. We have activities every 1 month or 2 months. And we already have multiple representatives from many Asian countries, including Bangladesh. We already have Dr. Amran Reza Chaudhry and Dr. Syed Muhammad Akram Hussain being members of Asian Cardio-Oncology Society. And I would want all of you, all oncologists in Bangladesh to, actively participate, take membership in Asian Cardio-Oncology Society. We already have collaborations, including with the Bangladesh Society of Breast Cancer Study. Now let us talk about breast cancer and cardiovascular disease. So breast cancer is the most common malignancy in females, and we have multiple cardiotoxic treatments, including anthracyclines, HER2 treatment, and radiotherapy. The cumulative incidence of major cardiac events, what we call as MACE, is around 4 to 5% at 5 years. And when the incidence of heart failure, when you are giving multiple cardiotoxic treatments like anthracyclines, trastuzumab, radiotherapy, is almost up to 20% at 5 years. So for many of our early breast cancer patients, the breast cancer related mortality is much less than the cardiovascular mortality, which is around 15 to 18% at 10 years. And that is the reason why we need to look at it. Further, those patients who are diagnosed with cardiovascular diseases, they have a higher 4-fold mortality risk than those who do not have. And obviously, we all look at the clinical trial data, but hardly we see that patients who are having active cardiovascular diseases are taken in clinical trials. So the real world cardiovascular disease incidence is probably much, much higher than this. And we need more data from our region in order to document our actual cardiovascular disease and cardiotoxicity rates. Now let us take an example of a breast cancer patient. Now, this is the typical patient that may present to our clinic, a 64-year-old female, postmenopausal, known case of diabetes and hypertension, and has underwent an upfront left modified radical mastectomy, but diagnosed with a T2N1M0 disease, which is ERPR positive as well as HER2 positive. This patient on routine evaluation is normal, doesn't have any active symptoms, and her 2D echocardiography shows a 55% left ventricular ejection fraction. Now, the plan of treatment for most of us is quite clear that we would go ahead with 4 cycles of anthracycline-based chemotherapy, followed by 4 cycles of taxanes and trastuzumab, followed by local radiotherapy, as well as trastuzumab maintenance and aromatase inhibitors. But then, if we really evaluate this patient from cardio-oncology concept, we would first be doing a cardiovascular risk assessment and then start the appropriate oncological management as per the risk. And during the treatment, we would be monitoring and doing surveillance for diagnosing any cardiovascular disease that develops as a result of treatment, and continue the oncological management with cardiovascular disease management. And post-treatment, we would look for long-term cardiotoxicities. Now, this is what a goal of any cardio-oncology clinic is. That is, before the treatment, we are more towards recognition of cardiovascular risks and their mitigation. During the treatment, the focus is on early recognition and treatment of cardiovascular disease and toxicities, whereas post-treatment, the idea of cardio-oncology clinic is mainly on surveillance and mitigation of the late cardiovascular complications. Now, in a routine cardiac evaluation, obviously we need a good history which is focused on cardiovascular risk factors and symptoms, a good clinical examination looking at blood pressure, pulse, saturation, BMI, JVP, pedal edema, and chest and cardiac auscultation, and investigations which will be focusing on ECG, echocardiography, and cardiac imagings and biochemistry. Now, these are the most important, cardiovascular risk factors that we would be needing to. For example, the age of the patient, the family history of premature cardiovascular disease, hypertension, diabetes, lipid profile, as well as the lifestyle risk factors of smoking, obesity, alcohol, as a sedentary habit and lack of exercises. Now, these are all classic cardiovascular risk factors that are there in our patients, and these need to be taken into account in a good history in order to understand the cardiovascular risk of the patient. Now, it is very important to manage these traditional cardiovascular risk factors. Now, for example, hypertension is a multiplicative risk in the presence of other risks. So, if hypertension is there over radiation therapy, the risk of acquiring coronary artery disease is 24 times. And in addition to anthracycline toxicity, hypertension contributes to heart failure 44 times. So, controlling hypertension, controlling lipid profile, controlling your diabetes, all these are very important factors even during cancer treatment. Now, talking about cardiac evaluation, we always talk about echocardiography. Now, echocardiography, many of us may believe that the ejection fraction that is given is not objective enough. And I must tell you that with the modern two-dimensional echocardiography using the planimetry method, if we are able to outline the heart and have a good echo window, 2D echo is a good method in order to assess the left ventricular ejection fraction as well as the structure of the heart. Now, a 2D echo which has a good software for GLS, that is the global longitudinal strain, will give you this strain pattern. And this is very important because this is one investigation that can give you an idea about an early cardiotoxicity which develops without even drop of the ejection fraction. So, this is very important in echocardiography. Now, many of us had this belief that a MUGA scan is very objective and gives you an objective left ventricular ejection fraction. But a MUGA scan gives you radiation toxicity, and a MUGA scan hardly gives you any idea about the cardiac structure. So, MUGA is something that is hardly recommended, and if you are not having a good cardiologist doing a 2D echocardiography, go for a 3D echocardiography which is reproducible, as well as you can go for a cardiac MRI which can give you a good and very reliable ejection fraction instead of a MUGA. Talking about cardiac biomarkers, now troponin are important biomarkers which gives you about idea about myocardial injury, whereas the natriuretic peptides, the BNP, gives you a good idea about the congestion in the chest as well as the strain on the heart. Now, these are important investigations that you need to look into. For example, the baseline global longitudinal strain and cardiac biomarkers are very essential to diagnose subclinical cardiotoxicity and instituting cardioprotective measures early for maximum cardio safety, which is the crux of cardio-oncology. Also, ischemic heart disease is something that often can come and confuse you about the cardiotoxicity, and in order to rule out coronary artery disease, you need to have a good suspicion. And if the pre-test susceptibility or the probability of having coronary artery disease is low, you can utilize non-invasive CT angiography in order to diagnose that. So, just as I said that the baseline measurement of natriuretic peptides and troponin is something which has a class 1 recommendation as per the ESC guidelines in order to detect CT-CRD and in high-risk patients. And echocardiography, 3D echocardiography, GLS, they are all class 1 recommendations. So what we learned now is that the baseline cardiovascular risk assessment is very important, and we need to look at the previous cardiotoxic therapies, previous cardiovascular disease, the age, the genetic factors, the medical risk factors the patient has, the lifestyle risk factors, as well as the ECG, echocardiography, and cardiac biomarkers. So based on this, we already have an European Society of Cardiology recommended risk stratification. Now, this is a very easy and simple risk stratification pro forma that is being recommended by the ESC for patients on anthracycline chemotherapy, whereby you can score the patients on what is their risk factor for having a cardiotoxicity, and similar one is also available for trastuzumab. So, if the patients are having one risk factor, they are low risk. If they have 2 or more risk factors up till 4, they are medium risk. If the score becomes 5, or if they have one risk factor, they are high risk. And if they have at least one very high risk factor, they become very high risk. And the risk of having cardiotoxicity increases from 2% to 20% when you grow from the low risk to the very high risk. Now coming back to the approach, so if we diagnose our patient with low risk, we can safely go ahead with the potential cardiotoxic treatment without much intervention. But if we have a patient who has moderate risk, we generally want to increase the surveillance a more stringent way, whereas patients who are high risk or very high risk, you need to relook at your treatment, try to institute more cardio-safe treatment rather than the cardiotoxic treatment, and institute cardioprotective strategies if you are actually going ahead with the cardiotoxic treatment. So if you come back to our case, what we see is that this patient, being a 65-year-old patient with diabetes, hypertension, already is a moderate risk category for receiving anthracyclines. And if this patient is obese or has baseline biomarkers or GLS elevated, they are going to become a high risk. If it is the patient is moderate risk, I would probably go ahead with my anthracycline treatment under strict surveillance, and cardiology referral is not absolutely essential right at the start of the treatment. But if this patient becomes high risk, instead of the anthracyclines, probably I would go to TCH regimen, which is a non-anthracycline based regimen. And if anthracyclines are used, I would make sure that I get a cardiology referral. I optimize the patient in all cardiovascular risk factors, and I would go for a strict surveillance of biomarkers and GLS, so that if there is any subclinical toxicity, I withdraw early and I start cardioprotective measures as soon as possible. And thus you see that if you do this risk stratification, it matters because your management changes. Similarly, for trastuzumab, again, if this patient received anthracyclines, the patient would become a high risk. But if the patient did not receive anthracycline, then patient can still be a moderate risk, and our plan of management is going to change based on whether the patient is high risk or a moderate risk. Now regarding preventive measures, ABCDE tool is very simple that we all can remember, and this is what is generally used in patients of cancer. So for A, you have to be aware of the heart risks. Aspirin if you are suspecting any ischemic disease. B for blood pressure and biomarkers. C for cholesterol and cigarette cessation. D for diet and weight management, dose management as well as diabetes management, and E for exercise and echocardiography. Now once we have started treatment, one of the most important aspects is to define and to catch a CT-RCD, that is a cancer therapy related cardiovascular disease. So cancer therapy related cardiovascular disease is something which is defined as a decline in ejection fraction by 10% to a value of less than 50%, or in the setting of new signs and symptoms of heart failure with elevated cardiac biomarkers. So there are multiple definitions and grading of CT-RCD, And we must note that the CTCAE grading does take care of the symptomatic heart failure, but the asymptomatic heart diseases and asymptomatic cardiovascular dysfunction, even the CTCAE doesn't have grading for it. And then there are multiple definitions, but more or less what we agree is that less than 50% ejection fraction with a 10% decline is something that we would define as CTCRD. Also, we have the European Society of Cardiology definition of both asymptomatic as well as symptomatic heart failure. And for management purpose, we may define heart failure as type A, B, C. Now, type A is something which is asymptomatic and only has preclinical lab abnormalities, for something which doesn't require active management but only surveillance, and maybe starting cardioprotective medications once you are sure of it. And type C is something where patients are in symptomatic heart failure, where you have to stop the cardiotoxic treatment and start heart failure treatment. Now, type B is something which is tricky, where the patient has significant reduction in left ventricular ejection fraction but is asymptomatic. And it is proven that in type B heart failure, if you do cardiology consultation, it improves the overall survival. If you institute ACE inhibitors and beta blockers, it improves 50% recovery in your left ventricular dysfunction, and this treatment improves cardiac event-free survival. Again, early intervention improves survival over a delayed intervention. And again, statins, exercise, diet, all these are again measures which improve the survival if you are instituting these measures early. Talking about medications, so for ACE inhibitors and ARBs, in first line we have evidence for enalapril, we have evidence for candesartan, and we have evidence for sacubitril/valsartan. And among beta blockers, carvedilol is something which has more antioxidant properties, so it is preferred as compared to metoprolol, which is less preferred, and bisoprolol is something that is preferred if you have bronchospasm or hypotension. For vasodilators, again it is an important treatment sometimes you want to use as a second line for blood pressure management, as well as when you are instituting fluoropyrimidines and you want to keep your patient safe from cardiac events. And here also the dihydropyrimidine calcium channel blockers are more preferred, and you don't want to prefer the non-dihydropyrimidine ones, that is the verapamil, diltiazem, because they have drug interactions. Among the aldosterone antagonists, eplerenone is preferred as compared to spironolactone, because spironolactone is known to have pro-estrogenic effects and can affect your management in breast cancer. Talking about diet, again saturated fats, no. Red meat and processed meat, no. Smoked food, no. And eating sufficient fruits, vegetables and fiber is a big plus, and we need to discuss this with our patients. Exercise is something that is very important. Peak exercise capacity, which is measured by the peak oxygen consumption, is something which is reduced in our patients of cancer, and patients can benefit from interventions which improve this exercise capacity. It is proven in research that patients with non-metastatic breast cancer have lesser cardiovascular events with increasing exercise, and exercise has been shown to reduce breast cancer related death as well as mortality. So, again another concept of primary and secondary cardioprotective measures. So, primary prevention is something that again we start in a patient who doesn't have cardiovascular disease yet but has risk factors, whereas secondary prevention is something where the patient already has a baseline cardiovascular disease or is being diagnosed with a cardiotoxicity during treatment, and there we institute secondary, and the measures are same, that is the ACE inhibitors and beta blockers and the statins, and of course we need to discuss about the liposomal variations as well as the dextrazoxone. Now, coming to individual cardiotoxic treatments, that is anthracyclines. So, anthracyclines, they have DNA damage by topoisomerase suppression. They cause iron incorporation in the mitochondrial respiratory pathway, causing cell membrane damage in the myocytes, and they also generate reactive oxygen species. The cardiotoxicity by anthracycline is a continuous dose dependent phenomena. It starts from the first dose itself, and it is much higher when there is concurrent anti-HER2 treatment, taxanes and radiotherapy. It can be acute, where we may have some arrhythmia because of anthracycline. It is rare, and usually most of the toxicities are seen late onset chronic, but with concurrent cardiotoxic treatment it can be early onset also. When you talk about the different anthracyclines, of course doxorubicin as a rapid infusion is probably the most cardiotoxic, but it's the most widely used, and the cardiotoxicity is 5% or more when the cumulative dose rises to 400 milligram per meter square. And as the dose increases, it increases almost up to 50% of your patients at 700 milligram per meter square. Regarding anthracyclines, again, when we are using anthracyclines, if we limit the dose beyond a cumulative dose of 250 to 300 milligram per meter square, we are going to prevent a lot of cardiovascular disease. We should give it as a slow infusion rather than bolus, because slow infusion is shown to decrease cardiovascular diseases. Liposomal formulations should be used wherever feasible as per the data. Dexrazoxone as an iron chelating antioxidant is something that has been shown to reduce the incidence of cardiovascular disease with anthracyclines to almost 4 times. But availability of dexrazoxone is an issue, and there is ample evidence to suggest that dexrazoxone does not interfere with treatment and does not impair survival if you use them. Again, with beta blockers, carvedilol is preferred. ACE inhibitors and ARBs, statins and exercise, they are all shown to decrease the incidence of cardiovascular disease with anthracyclines. So, what if your patient develops a symptomatic CT-CRD with anthracycline? So obviously, if it is a severe or a moderate, you want to stop it and you discuss in your MDT for alternative treatments. Whereas if it is asymptomatic and mild, we can continue the anthracyclines with cardiovascular monitoring and instituting cardioprotective measures. Regarding the outcome of anthracycline based cardiotoxicity, traditionally it is considered irreversible, but there have been recent reports and studies which showed that with early institution of heart failure treatment and early detection, anthracycline based cardiovascular disease can be reversible. And cardiopulmonary stress testing, where you measure the peak oxygen consumption. So a reduced VO2 is something that can be used as a predictor for survival and to monitor the recovery of cardio function in anthracycline based cardiotoxicity. This is the monitoring schedule that is recommended by ESC for cardiovascular monitoring during anthracyclines, and we see that for low risk patients we don't need much monitoring except a baseline ECG and echocardiography, whereas the biomarkers, the cardiac biomarkers, are also not having a strong recommendation. But for a moderate risk patient as well as a high risk patient, ECG, echocardiography and cardiac biomarkers, they are all important, and we need to repeat them even every 2 cycles in order to be very vigilant about the cardiotoxicity. Talking about HER2 agents, so HER2 is an important component in cardiac tissue, and it is important for cardiac stress response and repair, and HER2 toxicity is usually reversible. Trastuzumab is the most toxic anti-HER2 drug, whereas the toxicity with pertuzumab, lapatinib, TDM1, TDXD, neratinib are all less. So the main cardiovascular effect is an asymptomatic left ventricular dysfunction, which may be up to 10% at 5 years and 20% in combination with anthracyclines. And for heart failure, the data says that it is 2% with anthracycline combination, but the retrospective data, which is outside clinical data, which shows that the incidence of heart failure with anti-HER2 and anthracyclines can be up to 12% at 5 years. Now this toxicity is usually reversible on withholding and starting heart failure treatment. So similarly, the monitoring of cardiovascular toxicities in HER2 treatment in a low risk patient only starts with an echocardiography and ECG, which we need to do every 3 months, and at 12 months we can stop this monitoring and then can only do a 6 monthly echocardiography in patients who have not had any toxicity if they are low risk. But in case of high risk and very high risk patients, we need to do cardiac biomarkers as well as an echocardiography every 3 months, which should be continued.
Excuse me, you have 2 more minutes remaining.
Regarding management of HER2 based cardiac dysfunction, this is actually a bit tricky because it is reversible. So if there is asymptomatic decline in the heart function, we can continue the anti-HER2 drug under cardiovascular monitoring, and this is a class 1 recommendation, but we need to monitor the cardiac biomarkers and GLS. Whereas if the patient is symptomatic, then we need to interrupt the anti-HER2 treatment, give a heart failure treatment, and reassess the patient after 6 weeks to see whether the heart function is recovering or not. Also, I want to discuss these 2 studies, that is the Safe Heart study, which looked at the prospective evaluation of cardiac safety in cardiac compromised patients for using HER2 targeted therapy. So this was a small study of 31 patients where patients who had a baseline ejection fraction of less than 50%, that is 40 to 49% without any symptoms of heart failure were taken. Now these patients went to cardiologists, they started beta blockers and ACE inhibitors, and they went on to receive the anti-HER2 agents, that is trastuzumab, pertuzumab and edotrastuzumab. And what was found is that 90% of these patients tolerated the treatment well without any major cardiovascular event, whereas only 3 patients suffered a cardiovascular event or asymptomatic worsening in ejection fraction. Similarly, the Scholar study also showed that in patients who had mild cardiotoxicity on trastuzumab, there also we can safely continue trastuzumab. So in this study, again, it was only 20 patients where patients who had an ejection fraction decline below 50% to up to 40% or decline of more than 15% below baseline were continued on trastuzumab, where heart failure therapy was instituted and cardiology follow-up was done. And here too, 90% of the patients continued to receive all planned trastuzumab doses, whereas only 10% of the patients had cardiac events or interruptions. So, trastuzumab therapy is something that despite left ventricular ejection fraction decline we can use, but we need to discuss regarding the risk and the benefit, and we need to institute aggressive cardiac interventions. Talking about radiation, radiation of course has multiple toxicities, and we already have breath hold techniques, prone position techniques, IMRT and proton in order to prevent radiotherapy induced long-term cardiovascular side effects, and we have these cardiac sparing mechanisms. Obviously for radiotherapy also you need to see what is the mean heart dose, and you need to risk stratify the patients whether they are high risk, very high risk, moderate or low risk, and there is a recommendation in order to look at the scores, cardiovascular scores, in order to understand what is the toxicity. Also there are other treatments in breast cancer like immunotherapy agents, taxanes, platinums, the CDK4/6 inhibitors which cause QT prolongation, tamoxifen which it can cause thrombotic disorders, aromatase inhibitors which can cause hyperlipidemia, and PIK3-mTOR inhibitors which increase hypertension, hyperglycemia, hypercholesterolemia, hypertriglyceridemia. So most of the treatments that we see in breast cancer, they already have multiple high risk factors. Regarding the long-term side effects, again there is class 1 recommendation that we need to monitor these patients with echocardiography, with ECG and with cardiology follow-up, and there also we need to risk stratify the patients as to whether they are high risk for long-term toxicities or not. So with this, we understand that cardio-oncology is a complex area with emerging data. There is emerging evidence for cardioprotection. Many patients can complete cancer treatment with asymptomatic falls in left ventricular ejection fraction. Patient issues are definitely more pills, but oncologist issues are less now in practice, and with imaging and biomarkers, we are more likely to pick up changes between the groups and how significant these are. With this, I thank you all for patient listening, and would be happy to receive questions or any communications from any of you. Thank you.